So I have a PowerPoint I'm going to share here, and I'll go through that bit by bit, and then hopefully if there are any questions, you can bring those to class the next time we meet. So you should be seeing that now. I think you are. Make the screen bigger and start from the beginning. All right. Okay, so client assessment. That's my name. So what I want to talk about is an introduction to the social work perspective and the reason why we do assessments. What's some of the how social workers work within it, how we formulate our initial assessment, a thing called the DAC model, which we'll get into more detail with. Then we're going to talk about theory and conceptualization, and then we're going to talk a little bit about assessing through a psychodynamic perspective. So when we talk about assessment, we really want to start really thinking of it as a joint activity. This is something that goes both ways. This isn't sort of that old school blank slate kind of an idea. This is something that we want to engage people in, because when people are invested within the assessment, it creates a much more a lot more cohesion within the therapeutic relationship. And this is really, your assessment is really an opportunity to begin that engagement process. So we want to look at it as a joint activity between the social worker and the client. And we're really seeking within all of our questioning mutual understanding and agreement. So we want to talk about this concept of social diagnosis. So I'm just going to read this to you. It's Mary Richmond. So this lets you kind of know where we're coming from, right? This is one of our founders of the profession of social work, 1917. Social diagnosis is the attempt to arrive at as exact a definition as possible of the social situation and personality of a given client. The gathering of evidence or investigation begins the process. The critical examination and comparison of evidence follows, and last come its interpretation and the definition of the social difficulty. So I just want, as we're going through this, and as you're doing assessments in your agencies, to be thinking, are we actually diagnosing society? Are we actually doing that? Or have we really worked within a model that locates the dysfunction within the individual? And if that's the case, how do we unpack it to get back to this original concept? So some other things about a client assessment: it's an ongoing process. That makes it dynamic. You don't want it to be a one-time thing. How else are you going to know whether or not you're doing a good job? Being able to go back to original assessments and see what has changed, what goals have been met. I mean, this is what we do within our treatment planning. Hopefully, it's a constant reassessment process of the primary presenting issue and then the issues that are discovered through process. So it's dynamic, it's multidimensional. We don't just want to be looking at what's existing within the individual. We also don't just want to be assessing what they're reporting. We also want to be assessing how we feel in the space, how we're reacting to them, how they're reacting to us. So it's a multidimensional. It's a really interesting process that really builds upon itself. That this is the two most important phases of our work with clients are the assessment and the termination phase. The assessment phase, because if you don't do this one right, there's no second session, right? There's no middle if you don't engage them to the point where they want to come back. Also, if you misassess someone, you could start treating something that needs to be treated later or not at all, and you could be missing a major factor, and that usually leads to clinical burnout for the client, and because they really don't feel like what they need is being addressed. So, and then it goes all the way. The reason termination is so important is because you don't have another session after. So with both of them are really based on what comes next, right? We need to get the assessment right so that we can create the treatment that's appropriate and will actually be helpful, and that the person will be engaged in and feel some ownership and autonomy over. And then obviously in termination, we want to make sure that that's done correct as well. So we have this circle, the assessment circle. The client, the related systems, the worker, client related systems, worker, client related systems, right? And so there's an interrelated nature between the systems that are interacting during the assessment, right? So there's you in the room, and you are a great tool of understanding and assessment of the client, your own transference that comes up, biases that are produced, emotional reactions to the client itself, the datum that they're reporting, the physical presence that they have in the room, tone of voice, all those different things, and then the related systems that are both in and out of that space, right? They're bringing in the pain that they're having in life, but they're also entering into your system. They're in your waiting room, they're in your office, all of those different things. They had to deal with the reception area, maybe walking past other clients and what their reaction to the population that your agency serves might have been. All of those things enter into the assessment with them. You might be doing this at home, at their home. If you're doing assessments in a client's home, then all of a sudden there's all those related systems as well that might exist within the space, whether there's other people there, whether they have pets, whether they live in some type of assisted living where you had to go through a security, the other tenants that live in the space. All of those things are present during the assessment. So we have some constraints and factors of influence here. So first, there's that model of practice. And, an assessment at a hospital is going to look very different. Like a medical unit in a hospital is going to look different than the mental health unit, which will look different than a substance use unit, which will look different than a domestic violence unit, which will look different than a benefits unit if you're helping people find access to Medicaid or SNAP benefits or anything like that. So the model of practice changes the way that we approach it. It also creates certain constraints, right? If you're working with someone on benefits and they start to bring in trauma content, you're really limited in your ability to sit with and help them process through that content. There's also the language within a lot of our assessment protocols where we're limited by the documents, we're limited by all of those factors. So we want to look at model of practice. The agency's purpose and mission oftentimes steers us in one direction or another. Is your agency a trauma-informed agency, which will definitely shape the assessment documents and bring you in a specific direction? Are you working in more of a medical model? And we'll get to that in a few minutes. But those types of things place constraints and limits. The philosophy, your philosophy, the client's philosophy, the agency's philosophy about who people are and how they grow, how they suffer. And then contractual considerations within the agency itself. The client's contractual considerations, things like parole, probation, ACS, any agencies that might have some power over their autonomy. And then, of course, access, which I think is one of the most important things. Like how accessible is your agency or your assessment documents or your assessment presentation to clients based on their own intersectional social positioning. And obviously time, some of you have talked about being limited on time, 20 minutes, a half hour to do the whole job. Some of you have talked about having more extended periods, like being able to do an assessment over 3 visits. All of those different things add to either constraints or factors of influence. And of course, resources. How much can you actually give to your client out of an assessment? So assessment tools that we have standardized ones, graphic representations, written, historical, theoretical, personal interactions, professional, paraprofessional, the use of self. These are all tools that are built into the model of assessment. So we're going to talk about each one of these and what it sort of looks like from a social work perspective. So standardized tools, these are the tests, interviews, and agency forms. These are the written documents in a way. Some standardized instruments that we use. The Beck Depression Inventory is very popular. The MMPI, the Rorschach, the Intelligence Chest, Tile Behavioral Checklist, ASES, it's a tough one to say in company. We also now are seeing a lot more use of adverse childhood experience scores, adult attachment inventories. So there's no limit to the amount of standardized tools that are out there for us. Picking one, needs to be based in some sense of validity, right? Some of the instruments must be administered or interpreted by a psychiatrist. Like Rorschach is more of a psychological test. Child behavioral checklists, intelligence tests, those are more in the realm of psychology. But Beck Depression inventories, anyone can give those. So So we want to make sure that if we're going to use one of these tools, that we're taught how to use them. One of the more popular ones, so it has a really high level of validity and reliability. Um, Aaron Beck was doing research on cognitive behavioral treatment for clinical depression. He needed a method. He needed some sort of a scale. So they created this. It was a huge project, and it's considered one of the more reliable instruments that's there. There are some criticisms of it, that it's not as cross-cultural as it should be, that it focuses too much on the deficits. But overall, people still feel that this is a pretty good tool to use. I was going to have you go and look at it. There's the website. If you want to go take a look at it, you're more than welcome. Skip through some of that. The Rorschach scale, it's also freely available in the public domain. So Beck, you usually need to get permission and pay a lot of money, because if you want to become a rich social worker, you create a scale that everyone needs and you charge for it. But the Rosenberg is actually free, and it also has a high level of validity and reliability. So you can, if you want to, you can go take a look at that website as well. Graphic representations, we see a lot more. These are timelines, eco maps. We talked about eco mapping, geneograms. We've talked about that. Family sculpting. These are really great tools that social workers use a lot. And we tend to like them because they're very, very collaborative. You need the other person to be giving data and information in order to make these particular tools work. It's also it's not as verbal. It's not as it feels less invasive, because in one way or another you're creating a document together as opposed to asking questions and recording answers. Yes, so you can kind of see this is a level of eco mapping. We saw a different version of it, but you can kind of see that this is a family eco map. So we're looking at this particular family in context of the social connections and the social pressures outside of their life. Sorry about this. All right, so there we go. Yeah, and so this is just showing how we utilize the imagery, right? So you would need some sort of a key to explain what all those lines mean and represent. The sample timelines, these are fun to sometimes do with folks, because you really get a sense of what dates and what times they really focus in on. It can be helpful to sort of figure out when how a person was developing, and if there was trauma. If you've watched the other lecture, you can look at a timeline to look for those rupture moments, those moments that really, really redefined a person's identity and the sense of safety within their world. It's also an opportunity to see where timelines cross. Like you see the baby sister being born in 91. This is a young person. What point in their development did someone new come in? What type of relationship they had with that baby sister? How much of the oxygen was taken out of the room for them and given to the kid, and what did that do? So it gives you sort of a chronological way to talk to the person about their life. And in narrative therapy, you're actually starting to get a sense of the narrative that people tell themselves and who's writing it. So you take out a sheet of paper, create a chronological timeline of your life, and then do you think that a timeline would be useful in a client assessment? So I urge you to try this. Just do a little timeline of your life. You start decade by decade. So first decade, and then you can break the decades in half, and you keep going down until you feel it's no longer useful. But really taking a look at, like, how do I choose the poignant moments of the decades of my life, or how do I choose the poignant moments of every 5 years, or whatever the case might be, and do it for yourself and see if you think it would be useful. Then we have what we're more commonly used to is the written assessment tool. So an intake contact forms, these are usually standardized by agencies. A lot of times parameters are laid down by funding or government regulatory bodies. Our notes, they're sometimes standardized by agencies, especially if specific language and wording needs to be used for reimbursement. We also have the very common problem lists, needs assessments. We've talked briefly, well, actually pretty extensively, about biopsychosocials. So when we talk about historical assessments, these are the written records. They're documents generated by someone other than you. So sometimes we call them collateral, sometimes we call them historical. But these are like you going and finding a person's medical record, or you getting access to former psychological reports or psychological testing, or even, you know, getting a discharge summary from another agency before your client starts. You know, getting write-ups about things from their parole officer, probation, getting an ACS report. So anything that's written by someone else that comes into your world. Records that are sent as part. Yeah, I just said that. They're useful, but we've got to be cautious, you know, because you know, truth is an evolving process, and you know, we don't know the people who wrote these things. We don't know what their biases were. We don't know what their agendas might have been. We don't know what shape our client was in when they were with them versus where they are now. Also, we don't know if these people were working from a strengths-based or deficit-based perspective. So we have to understand that they can be useful in giving us some nuance and some additional information, but we don't want to hold so tightly to the history that we lose a sense of the present moment with the person in front of us. So those are the basics of what we bring to the idea of assessment. Now we want to talk about what social work does. So our unique perspective, it changes the way we look at this. It becomes that social diagnosis. We also bring in the theories that we learn, that you're taught here, and they're by no means the only ones out there, or maybe even not even the most appropriate one for you. As you go forward in your careers, you'll find more and more theories, and you'll hopefully find the one that kind of guides your work. But the big one for us as social workers is PI, person and environment. And we want all of our assessments, all of our engagements, all of our treatment plans to be centered around that aspect, so that we don't get so reified on diagnoses or labels that we start to stop seeing the person and the interplay between them and the environment. So we want to always keep a strengths perspective. We don't want to be deficit based for a lot of reasons. One, it sculpts the way we work with the person, and we tend to have a very narrow view of them. But also, when those documents that we're creating become the history documents for some other clinician, do we want the only thing for them to read are the deficits of our client, or do we want them to see them as a more complete and whole person? So then our systems and ecological theory guide both the person and environment and the strengths perspective. So your interaction, this is where I talked about you are in the room, and how you're feeling with the person is a huge part of what happens in there, right? It's a valuable assessment tool. If you're sitting in the room and you're kind of feeling really creeped out by your client, that's an important thing to note, right? If you're starting to feel angry, if you're starting to feel disconnected, if you're starting to feel tired when you weren't tired before, all of those things are really valuable to figuring out what's happening within that individual across from you. And this can go for any type of contact, telephone, emails, text messages that you might get from clients. The reactions that you're feeling are important. So we want to also, yeah, so the personal interaction piece and this kind of idea of formal intervention, remembering that assessment is an intervention technique, right? It's you're intervening to try to gain enthusiasm and motivation from the client to seek help. And that's one of the purposes of this connection. So we have the formal interventions. This is like when we're right there with them, we had a scheduled appointment. But then we also have informal contact. You know, this is like bumping into your client in the hall. They bump into you at the grocery store. You know, you're giving a tour. Every setting is going to be a little bit different, but those interactions, we don't want to stop looking at the clinical significance of bumping into someone in the hallway, right? Or walking past them in public. Those informal contacts can a lot of times shape a lot of our work. Now, the interprofessional and paraprofessional collaboration, this is like when we're working with people who are involved in sort of agency systems, whether it's doctors, teachers, psychologists, physical therapists, bosses, all of those different things. Those are, we consider very collateral. And the information that we gather there, it's very similar to the histories. Even supervision and peer collaboration, those would also be considered the professional aspect of collaboration. So the reason that we talk about this is that we want to understand that we're not making this assessment in a bubble, right? So there's going to be other factors, there's going to be other voices, there's going to be other things involved in assessing a client that are incredibly useful for us, because what we really want is to gain clarity, right? We really want to understand this person as the complex being that they are, and understand that person within the context of all of the different players in their life. And this is one of the harder things when we're limited by time and all those other barriers and limitations we talked about earlier. How often do we get the opportunity to really engage in all of these different layers? But how much more powerful our work would be if we could. So the use of ourself, this is something you'll be, grappling with and discussing in all of your classes, especially our time together. But these unique characteristics and skills that you possess, that you bring into the space, being able to assess how well that your uniqueness is going to help the client or hinder the client, right? Do you have these aspects that are gonna, hopefully you're all learning to do research. You're learning more and more about specialized knowledge and training, things that you're really gonna connect with during your time at NYU, your own personal experiences, your values, all those things. And then now hopefully the ability to research, but these also work on the other end, right? Like we could have a lack of knowledge about a specific client. We might have values that are contradictory or that create bias. We may have had past experiences that create unhealthy countertransferential situations in the room. And we may not really like reading research, which can be a big issue because we want to make sure that we're using things that are evidence-based, and we need to be able to tell the difference between the two. So the use of self is also a call to work on the self, right? To make sure that we're improving in all of these areas whenever we can. So one of the major stumbling blocks, I think, for a lot of social workers is this concept of interaction between social workers and the medical model. So our work is not based in a medical model. Even when we're working in hospitals and doing medical-based social work, the fundamental aspects of social work are not based within that medical approach. But we interact with these systems all the time in the benefit of our clients, or we're employed by folks within the medical model. Sorry about that ridiculous picture in the bottom corner. So medical model is based just a practice based on the belief that the client has an illness, disease, or dysfunction which needs to be treated by trained professionals. So just in the definition, the language of the definition, I imagine it brings up some things that feel not so social worky, right? The patient is first diagnosed and then treated. Social workers, we have to coexist and interact and work within the systems dominated by this medical model. But if we look at it as collaboration, as opposed to like this idea of coexistence or, us against them kind of a thing, collaboration is possible, but we can't collaborate to the point where we lose our perspective. And this is really, really challenging, especially if you're working in a medical area. It's hard to be the voice of the person and environment. It's hard to be the voice that's combating depression when you're working in an emergency room, right? But that doesn't mean that we don't do it. It's actually a part of what our mandate really is to bring our ethics to bear within models that don't see that the way that we do. So the DSM-5 is a great example of a tool from the medical model that we as social workers are using and learning. I mean, you're literally learning in HB3, how to use this to diagnose people. It was written from the perspective of the medical model. So it's all about deficit. It's all about categorizing the symptoms in order to come up with an appropriate treatment. The ICD-10 is the International Classification of Diseases. So it's based on the World Health Organization's classification of diseases. So again, medical model. It tends to be viewed as a little bit better than the DSMs. And a lot of times it's used for billing because the new DSM doesn't have as simple of a coding system as the ICD-10 does. But so you can see these codes are required by Medicaid and Medicare, as most insurance companies. As someone in private practice, I can tell you the ICD-10 codes are everything when it comes to being reimbursed from insurance agencies. So DSM and ICD, they're very, very similar, but one shouldn't be used in place of the other, you know. So I feel like I'm not talking enough about this. Maybe we can bring this into the discussion about working within the medical model. The big thing is that we want to be the voice of the person and environment when we're working in those areas. And we want to help other clinicians start to use the language of inclusivity and strengths when they're talking about their clients. So the DAC, this is sort of a way to kind of think about how we start to formulate and create a treatment plan. So description, assessment, and contract. That's what each one of the letters stands for. So what you're talking about is a social history, an initial assessment, and a contracting model. So notice that this social history comes before the initial assessment. And I want you to think about your agencies and where the social history falls in this construct. Right, so usually in agencies, it'll be the initial assessment, then the biopsychosocial history, then contracting. So it's interesting that the DAC, the DAC, wants us first to look at the person within the social model, right? So the social history model has three major divisions: description, assessment, contract, right? So what does each one of those look like? Description, client identification, systems. So you want to really look at them from the micro, meso, macro level. So we want to be asking them questions about their own person, what's bringing you in today, then family and household, you know, how is your family reacting to this? How are they supporting you? How are they creating barriers? And then ecological, like where do you find yourself in the world? What type of work do you do? You know, what type of systems are you interacting with? How do you feel about yourself out there in the world? You want to identify issues of concern at each of these levels. You also want to identify strengths, competencies, and resources at each of these levels. Referral sources and collateral information at every level. You know, persons, who's your best friend? Who, if you're in AA, what about your sponsor? What about sober friends? Like, who are the people in your neighborhood? You know, and also looking at folks who they feel like they can count on that aren't necessarily part of the family or household. This can be incredibly important when you're dealing with folks who are homeless, very important when dealing with members of the LGBTQIA plus community, anywhere where we can see people developing family of choice out of necessity for attachment and connection. It's very important to know who those folks are. And then, you know, also this helps us with referral sources and to gain additional information when we need it. So we want to look, this is the descriptive, the social history, developmental history, personal and family, critical life events, sexual history, substance abuse, medical, physical, legal, educational. So you'll notice most of these are coming directly from the biopsychosocial stuff that we talked about last time. Then we get into the actual assessment piece. So the environment, resources, social and culture. So we're looking at person, identity and structure, mood and emotion, life cycle development, competence, risk, family and household assessment, identity and structure, mood and emotion, life cycle development, competency and risk. So we want to do the same thing at each level of the person's life, the micro, macro, meso levels. And in the environment, we're looking at resources and social and cultural factors. So after we have looked at that social history, after we've engaged in that more direct assessment, we want to take what we've learned and start to contract with them on a plan. So we want to make sure that it addresses their identified issues, your identified issues, and agree upon issues for work. So a lot of times a client will come in and be like, if I just get a job, everything will be great. And you're thinking, if you don't stop drinking, you're never going to be able to hold down a job. So these issues discussions are times when you can have that conversation where you can say, you know, I think that you're right. Long-term, a job takes care of a lot of your problems. But I'm feeling just from what you're telling me about your family, your environment, and your personal history, that we may need to address a few of the barriers to you getting and keeping a job before we really put you out in that way. And so you want to make it, again, collaborative. You want to make sure that their identified issues are in there, but also you want to bring your clinical knowledge to the work. You want to set goals, plans, you know, the action plan. What are you going to do? If it's within your agency, you know, how often do you want to come? What type of services make sense for you? Yeah, so you want to talk about each level. Like how do we utilize treatment plans? Is it going to be every 3 months? Is it going to be every week? What are your steps? What are the expectations of what the client will do? What is the work going to look like? What's going to happen in our sessions? What does therapy with me look like? What does their group therapy at this agency look like? Maintenance tasks. Are we going to have to do urine tests? Are we going to have to write court reports? All those different things. And then coming up with a plan to evaluate the progress, to really be able to sit down after an agreed upon amount of time to say, are we seeing the action working? And if not, why not? And if not, what can we do to strengthen the overall process? And that may require a new assessment, a different way of looking at it. So once we get those treatment plans together, it's how do we then communicate that to our agency, to the other people who are involved in the client's case? And that's with our records. But things that we have to remember about our written records is that they are legal documents. So your written record can be called into court. Now a subpoena, if you ever get a subpoena does not mean you have to do anything except respond to the subpoena. You always want to respond to it. And you can just tell them, I need time to speak with our agency lawyers to figure out the best way to get you the information that you need with our client's best interest in mind, right? A court order is different. If the court order comes down, then you're most likely going to have to turn over documents. But outside of those, your written notes are usually fair access to insurance companies or auditors, depending on the levels of consent and privacy within your agency. So you want to know what those are. But because they're documents like that, they should be accurate, right? You don't want to be called out on something that didn't happen. The dates need to be correct. The times need to be correct. The duration of the time that you're with them needs to be correct. They've got to be timely. You can go to court saying, oh, it looks like you just wrote this progress note 2 days ago. You need to make them within a specific amount of time that's necessary for your agency. And you want them to be terse. You don't want them to be long-winded. You don't want there to be so much information there that people can use it against them, right? So you don't want to be judgmental. You want to avoid big, long descriptions of things. You want to keep it short and sweet. You would write nothing that you cannot defend to your supervisor, professional organizations, state agencies, or the legal system of the client. Right? And again, they can be all of those things. So that's sort of your assessment in a nutshell. That's the information gathering. But then we come into this larger thing that sort of permeates the work we do, and that's the concept of theory. And so now you've gathered all of that information, and you've got to come up with a theoretical formulation of who your client is, where are they positioned in this vast universe, and what do you think is going to be the most effective movement forward. And so you're developing a theory about your client, about the phenomena that brought them in, the main issue that brought them into the space. And so this is what we talk about by practice theory. So you're learning in school, you're learning historical theories about humanity, about what wellness means, about what development looks like in a perfect situation. So you take that and then you put it into practice, which is completely different, right? Because theory is grounded in the abstract and practice is grounded in the real. So here you are, right? You're literally hearing the realness of another person, and now you have to theorize about it. And that will be influenced by the theories you've learned and your own view of, what wellness looks like and what help looks like and all those different things. So theory, it's an idea. An idea is a relatively unstructured thing. It's the building blocks of our conceptualization. It's okay to start theorizing about a person when you meet them. A little typo there. Theories add structure and discipline to our ideas. So you have this sort of abstract view of the person, all of this competing information from collateral sources and historical sources. You've used your scales. You've used all of these things to come up with a beautiful sort of abstract tapestry of the person. And now, as you theorize or formulate all that information, this is where we bring in structure to what we want to talk about. So what's our conceptualization? That's the first real process of this. You're assigning words to ideas, right? So when when you felt like the client was ignoring you, what word do you give that? Is that resistance? Is that tangential thought? Is that word salad? Like, how are you describing the ideas, abstractions, and constructions of the reality that you witnessed? So when we talk about, yes, I like that definition. Usually I say theory is an attempt to explain a phenomena. But this is interesting because this is talking about we cast a net out to try to catch a piece of the world. And when you're doing an assessment, the piece of the world you're trying to catch is that client's individual piece of the world. And then try to put it in a way that will help them, of course it's a philosopher, that will help them gain deeper insight into who they are and move forward in a more authentic place that's safe, right? So there's another definition, Cynthia Bisman. In drawing patterns of observation to explain phenomena, different persons may explain the same event with a range of theories. The theory is not real, but rather is in the individual's attempt to explain real things, right? So that's that dance of the abstract versus the real. So understanding as you're coming into this formulation that because it's theory, it's not an exact science, right? And they have their own theory of what's happening within their life, and that has validity. Like, we want to make sure that their opinion of things and their assessment of themselves and the world and what would be helpful for them is incorporated into our description. It may be in complete opposite to our theory of what's happening and what's needed, but we want to make sure that it's in that assessment so that someone else reading it understands that there's more than one view of what's happening. And so that's why this theory should be created in the collaboration of this assessment process. So this is the big question that you need to take into your own work. How much of our worldview colors and influences that assessment theory? You know, if you believe that addiction is a disease and the client believes that it's a moral weakness, how do you connect those two together? The client may be wrong. All bits of science say morality doesn't have anything to do with dependence upon a substance, but that's their opinion. That's their theory of what's happening. And for you to be able to put those two theories in a space together, immediately you can see where some of your work lies. But what if it was the other way around? What if the client came in saying, you know, I know that my alcoholism is a disease, and your opinion was that it was moral turpitude, and that people just drink because, you know, they want to, and they're taking advantage of the system and all those things. What if that was your worldview? How would you put those two things into the assessment, right? Hopefully you'd work through that other stuff so that you're not putting in the assessment. But those things collide. Our opinions and our theories collide. So theory building, it's a big part of the assessment process. This is where we are conceptualizing the situation, and we're doing it in conjunction with the client. We're looking for this idea of cause and effect, the if-then propositions, right? Like, if this happened, then that happened. And so you're also doing this with the treatment plan. I mean, you're talking to them like about if you went to AA, then what might happen, right? If we're talking about a treatment plan where the person is saying, you know, I really need to leave my partner because they're abusive, but if I leave, then I don't have any money, or then they'll come after me, or then they'll talk about me. Those propositions are really important to explore because that's that individual's theory. And so we need to work within that reality to help build a plan that addresses the barriers to success that they've identified and the barriers to success that you've identified. So this is, all of that is sort of the background noise to this, the first session, right? When they come in for the first time. What's the purpose of the first session? First purpose of the first session is getting a second session. I mean, when all else fails, you could forget a whole bunch of documents, you could forget to ask the questions, but if they show up a second time, there's the opportunity for repair. But if we don't get the first session right and they don't come back, then there's nothing we can do, right? So that's the purpose. What's helpful to know prior to the first session for you, each of your agencies, I want you to kind of think about number two in relation to your clients and your work. what would you want to know prior? Like what type of collateral information would be helpful? Because sometimes we can think of our agencies as, we're just sort of stuck. This process is how it's always been, but we can push for things. Like if you have an intake coordinator, and it would be helpful to know, if you're working with young people, it would be helpful to know what their grades were before you met them for the first time. Could you work with the agency to make sure that a consent is in place to speak with schools officials to gain that information? Is there room in the intake coordinator's job description and time for them to do some of the digging to get collateral information for you? Can you create that as an aspect, an automatic aspect of the agency? So thinking about what would be helpful to know prior to the first session is incredibly helpful for your agency as well as you. And then the third, the role of safety in the first session, really trying to create an environment where the person feels comfortable enough to engage in that collaborative experience. So purpose, get the client to come back, find out the nature of the issue. Who are you and why are you here? The basics. I mean, if you get to second, third sessions, you can get into more in depth, but what is really on fire in the person the moment that they come in to the room? Allowing them to tell that story, and really listening to all those other factors that we've discussed before we jump into assumptions. And of course, we want to assess risk in that first session: suicidal ideation, homicidal ideation, any health issues that might be present for the individual. So we really want to make sure that the person is safe within their own bodies and within their own minds during that first assessment. We don't want to leave those things out. Those are uncomfortable things for us to talk about, but they're incredibly important. And then the big one is to make sure that they're interviewing at the appropriate level of care. If someone is coming into your outpatient substance use clinic and they are actively psychotic, that might not be the right level of care for them at that time. And does your assessment really have space for that type of referral? If you don't know where your agency refers people who are suicidal or homicidal, find out, because that will present, and you'll need to find the appropriate level of care for that person. Does your agency have a referral source for substance use issues? If someone comes in drunk, do you know what detox you would send them to? How would you handle that? Make sure that you understand the policies so that you can meet them where they're at, and you can help them get to the level of care that's most appropriate for them. So some of the things that's helpful to know prior to that first situation, just in general, demographic information. It'd be nice to have an idea or a picture or a sense of who the person is. We talked a little bit about this when we talked about tuning in, right? Any prior diagnosis with symptom explanation. This is helpful. One, we don't talk enough about the reason for diagnosis, but one of the main reasons to diagnose a client is to create empathy within the clinician, right? To give us a sense of being able to feel as close as we can to what that client is feeling. And if someone comes in with a diagnosis of paranoid schizophrenia, I can extend empathy and place myself in that position. If that's my presentation and I'm coming into this strange space with this strange person, what might that feel like for me? And if I can place myself there, what could I do as a clinician to try to create a more welcoming and more inviting space? Maybe I don't immediately bring the person to my office. Maybe I sit in the waiting room with them and talk to them just generally about what the process is going to be like, ask them if there's anything that they need, trying to create a sense of safety within there. And then symptoms explanation can be helpful. We don't want to hold on too tight to any of this, but if we know that the person has a history of auditory hallucinations, and we see them actively sort of looking into the corner as though they're listening to someone other than you, that's important to know, because that lets us know something about where they're at in this moment. And we might want to check in on medications and last time they took them, what their sleep pattern is like, any of the things that can add to those types of presentations. Collateral contacts, we want to know who's involved in the person's life before we meet them, and any information that they've sent forward. Any progress notes, discharge planning, any needed consents. It's always a struggle when you're in a session when they bring up somebody to have to stop the process and grab a consent. I mean, we have to do it. It's unavoidable, but it's great if we can get some of the main ones out of the way, like their probation officers, ACS workers, their wives, their partners, whoever is really intimate and is is sort of a given that there's going to have to be a consent, you want to get as many of those out of the way as possible. Referral sources, it's nice to know where someone's coming from, because that can tell a lot about their motivation. You know, I think about folks who are working with post-incarcerated folks. There's an assumption of them not wanting to be there, and a presentation like that. But that referral source can tell you a little bit about what motivation is there, who's sending this person here, or what type of a situation created this relationship, right? And then this is the big part that we ignore a lot in assessments, and that's to familiarize our client with the agency and the process of counseling. You know, talking to them in the room about who you now are to them. It helps them gauge expectations. It helps them understand what you can do and can't do. It's a great beginning exercise in creating boundaries. It also allows them to decide whether or not this is the right level of care. They might need to come to outpatient 5 days a week, but they might not be ready to come to outpatient 5 days a week. So this, being open and honest with them about what the agency is like, what the process is like, will go a long way to help them determine whether or not this is the right fit for them. What our agency does, how often they'll attend, when the next appointment, and even just a summary of the next session. You know, being able to say, you know, I would usually follow up the first session by saying, you know, we've talked about a lot of things here. You've given me a lot of great information. We use specific assessment documents, and I'll go back and see which questions we've already answered. In our next session, we're probably gonna have you sign some more consents. We'll talk about that, and I'll ask you any specific questions that we missed from our conversation here, or whatever it is, whatever your next appointment is. You want to be as consistent and as authentic and transparent about the process as possible, because you want to model those aspects as well. You want to model transparency so they feel more comfortable being that way themselves. When it's time to write up the session, you want to give the description of the client, description of the problem. You want to give the relevant history, because you're going to gather a whole lot of information, and you don't necessarily need all of it. So you almost want to create your own timeline of the session, the same way that we did the timeline of their life. You want to do a timeline of the session and what relevant history you got, what part of it's interesting when you ask about mental health with someone and they end up talking about abuse in the home as opposed to mental health. So it's interesting to write that during the portion where we're reassessing family history of psychosis, they brought up violence in the home. So they admit there's a possible connection or attributing violence in the home to mental unrest. So those can be important connective factors when you're writing the history. The mental status. Every agency has their own version of this, but a mental status exam is really important in helping you sort of target and figure out some of the more prominent defense mechanisms that the client uses, a little bit of an understanding of their personality. Any active psychosis or any active mania, mental health stuff will usually become more apparent when you do a mental status exam. You always want to incorporate suicidal and homicidal ideation or plans. You want to get as thorough a medical history as your agency allows. Current medications, this is super important. Don't forget allergies to those medications. And when you're talking about medicines, you want to know about the type, the dose, the schedule, the prescriber, the amount of pills they have left. That's incredibly important. Their satisfaction, compliance, side effects, all that stuff. Allergies are very, very important. Allergies to medicines as well as foods and all of that. History of substance use, previous mental health treatment, diagnostic impressions, recommendations that you have for that person. So as you're writing this up, you really want to make sure that you are getting a really good basis for your relationship with the person. I just want to stop share here. Oh, I already did. Okay. Yeah. So when we're doing this, we want to create as clear of a picture of the individual and how they sit and how they interact with all of the things that are within their environment. This presentation was really specific about the nuts and bolts. As we get, especially next semester, more into the nuance of direct work with people and what it looks like, some of this stuff will become more relevant. This is really where we set the foundation for the relationship that we have with our client And it's also a really important opportunity to create a relationship between the client and the agency. On a outside, it's also an ability for us and our agency to create connections with collateral resources and sources. So assessment is the takeaway, hopefully, is that it's a multidimensional in a lot of directions. Good assessments are helpful to agencies because they do create networks, they do create connections, they do help keep clients engaged, which a lot of funding sources will base it on, how well do you maintain clients for at least 90 days. And if they see a lot of in and out assessments, people come in and then leave, how much are you really helping if the massive majority of your clients come once and never come back again? So assessment can be really important at that sort of macro level. A good assessment can be really healing for families if you're involving them and you're allowing their ideas and concepts to be a part of the process. It can be very healing and joining. We never want an assessment to our client to feel like an isolation tool. We want to make them feel connected. We want them to understand that they're coming in as this multifaceted person, but the treatment they're receiving is also multifaceted. That it's not just you, but it's this entire agency that is going to be mobilizing on their behalf. And we want to set realistic expectations and model authenticity, transparency, and really set the stage for a collaborative relationship with our clients. And this is true whether it's a one-time assessment for benefits, or you're going to be working with this person for the next 10 years. This assessment phase, it's the second most important phase that we enter into. But it's just vital to all of the work that we do. Even at an advocacy standpoint, when you're doing an assessment, you're hearing about the struggles, the oppression, you're hearing about the underlying systemic things that are creating the suffering within your client. And that's important information for you as a social advocate to have. Maybe you're not necessarily able to do something directly for that client at a social justice level, but maybe hearing their stories and making appropriate way out to a larger community so that change can start to occur in that regard. So hopefully this was helpful. You can watch this at your leisure. I will keep it active until the end of the semester, and then I'll take it down. But yeah, I hope it was helpful. If questions come up or you want some more clarity about a specific area, please feel free to ask during class or shoot me an email, and we can start an ongoing discussion about that. All right, so I will see you in class. Take care.